You are now listening to part 2 of the lecture on suicide and non-suicidal self-injury. We have just completed the assessment portion of assessing our patient using an evidence-based practice tool such as the Columbia Suicide Severity Rating Scale. Now, of course, we are assessing the patient's suicidality, but we are also assessing other things as well. For example, if there has been a suicide attempt, we need to complete an assessment on our patient to find out if there have been any physical symptoms related to the attempt. It is a good idea to complete a full head-to-toe assessment on any patient who is being admitted with any sort of suicidal problems or any sort of problems altogether. Remember, our mental health patients do also have physical problems. So after we've completed our assessment, we are moving into the problem list or nursing diagnosis phase of the nursing process. At this point, we are going to create a list of problem statements. And so some of the problem statements that relate to suicide might be things like potential for harm. You would say something like potential for harm related to, and that's the why of why they tried to commit suicide. So for example, let's say that someone had an overdose attempt and they say that they're still having thoughts of suicide, but they don't have a plan for right here on the unit. And you find out when you give them the Columbia Suicide Severity Rating Scale that they have had 2 previous suicide attempts. Then you might say X patient has a potential for harm to self or others as evidenced by suicide attempt by overdose, verbalized continued thoughts of suicide with no plan for on the unit, and 2 previous suicide attempts. Now, after we create our problem statements, we are then going to move forward to our outcomes. Now, I want you to know that this is not the only nursing diagnosis statement you might have related to this, but this is one that needs to be included on every single patient who does have a suicide attempt. We need to recognize in the care plan that potential for harm to self or others. Other sorts of nursing diagnosis related to this might be related to verbalization of feelings or depressive symptoms or something else. Now let's go on to our outcome statements. I think I've already taught you in other classes that when we write outcome statements, we need to use SMART goals. So after we've come up with our problem, which is our potential for harm, we need to develop a SMART goal related to this. And a SMART goal is simply an acronym that stands for specific, measurable, attainable, relevant, and time-bound. And because we are treating a person, it has to be personalized because remember, we are working toward person-centered care. Now, oftentimes, a patient at this point won't be able to formulate their own goals for treatment, but we do go ahead and make the goal for treatment that they aren't going to have any injury while they're in our care. And hopefully, over the next few days, as they start to get better, they can help us to be able to formulate other goals as well. So we first of all personalize it by saying patient X or, Margaret Smith, Brad, whatever, will remain free from injury while on the inpatient psychiatric unit with an anticipated discharge date of, let's say, 2/24/98, whatever. So remember, these are going to be maybe 1 or 2 weeks in the future when we come up with that discharge date. So we want our patient to be free from injury while they're in our care, and this is the date we anticipate discharge. This is specific. This is measurable. We can see whether or not they suffered injury. It is relevant to somebody who has a suicide plan, and it is time-bound. So it does meet that SMART goal objective. Here's another example. Patient X will complete a suicide safety plan by X date. Many times, one of our goals on the unit is going to be to work to create a plan for what happens if they ever have suicidal thoughts with intent to act again. So we would again say Margaret Smith or Brad, whatever, will complete a suicide safety plan by, and let's say 1 week. So we'd say, 3, 4, whatever year it is. So that's an example of a SMART goal because it is specific. We can see whether or not they completed it. It is measurable. Again, we can see if they've completed it. It is attainable because they will work on it in group. It is relevant to their care, and it is time-bound. Now, The next thing we are going to do is think about how we get to our SMART goals. Obviously, if one of our goals is to complete a suicide safety plan, we actually need to assist our patient in completing one. So think about planning interventions based upon risk and protective factors. And so when we're planning interventions to keep someone safe, we have to look at assessing those risk and protective factors. We want to find out if the patient's suicidal ideation has gotten better if we're trying to keep them safe on the unit. So we're probably going to assess that pretty frequently, and this will largely be determined by the institutional policy. In the case, for example, of St. Anthony's, they have determined that it's appropriate to assess a patient for suicidality every 8 hours. Now, this doesn't mean that you're asking them, all the time, are you thinking of suicide? Or are you thinking of suicide? It means that every 8 hours you're asking them that question. But that's not the only thing you're doing. In the meantime, you're observing them and you're doing other things to keep them safe. But our assessment piece, the main one where we ask them questions, only occurs every 8 hours. Then we're going to continue to monitor them. We're going to monitor our patient based upon their level that they need related to their suicidality. If they have an active plan for on the unit, we need to monitor them more closely than if their plan is only for the outpatient environment. And if they are intending to act upon suicide, we need to monitor them more closely than someone who would have vague suicidal thoughts. So you might see monitoring being maybe every 15 minutes, or you might see it being line of sight, or you might see it even being a one-to-one intervention for a very suicidal patient. The other part is we're going to remove environmental items within the environment with which the patient could harm themselves, and this can be one of our interventions. We're going to monitor the effectiveness of the patient's antidepressant therapy and assess them for side effects. So these are just a few of ways that you might have interventions that get you to those SMART goals that we're trying to meet. So please use your book to look at some other ones. Now, obviously, we do need to evaluate whether or not our patient has met the SMART goals, and we certainly need to do it by the date that we have indicated. But usually we're going to look at these on a daily basis and see if they need revision. For example, if one of our interventions, one of our goals is that our patient will be safe on the unit, and our patient has had a suicide attempt, we might need to revise our interventions in order to monitor that patient more frequently. So as we evaluate, we go back and we modify other pieces of this plan of care to see if they need revision. One of the biggest things on the psychiatric care environment is creating a safe environment. We want to remove any items with which the patient could self-harm, but we also want to look for ligature risks that may be present in the environment. Most hospitals have gone to great lengths to create environments where ligature risks are very difficult. For example, you will often see solid-state ceilings within psychiatric facilities rather than drop-in ceiling panels because the solid-state ceilings make it impossible for someone to connect something to the ceiling with which they could hang themselves with. You'll see doorknobs that slope downward, and they aren't the normal kind of doorknobs that just kind of stick out. You'll see glass that has been modified to create glass that is impact resistant so that patients can't break it and use it to self-harm with. All of these things are part of creating a safe environment, and the Joint Commission has told hospital facilities that when you have patients who have been screened for suicide and they are at risk, that we need to place them in ligature risk modified environments, and we need to increase our level of observation with those patients. So this is why in a medical surgical unit where you cannot modify the environment to create something that is more ligature free, you are going to have to actually increase the level of surveillance in that environment. So even though a patient may be only, moderately or a little bit high on the Columbia Suicide Severity Risk Rating Scale, we're still going to monitor them with a top level of supervision when they are in these environments that have not been modified to address the ligature risk. So think about it this way. If you have an IV pole, for example, that could be a ligature risk. If you have bed railings, that could be a ligature risk. So in these non-modified environments, the level of surveillance has to increase. But when you get into a psychiatric unit where the environment itself has been modified, sometimes that level of assessment or level of observation can be stepped down. So let's talk just a little bit more about levels of observation, because this is one of the most important interventions that we will do in the psychiatric care environment, especially when someone has had a suicide attempt or is expressing suicidal ideation. There are 3 different levels of observation. The first is 15-minute rounding, and this is one that is appropriate for individuals who are not a super high suicide risk. Maybe they've been on the unit a few days, they've kind of worked the treatment plan, they seem to be feeling better, and they don't have an active plan on the unit, or maybe they didn't make a very serious suicide attempt to start. Maybe they just had suicidal ideation and they were admitted to the unit. This is the type of patient that 15-minute rounding is appropriate for. Line of sight, on the other hand, is one where they're at risk for suicide, but they're not actively trying to harm themselves in front of you, and they're somehow in a modified environment. So, for example, this is your patient who maybe had a pretty serious suicide attempt, or they're in their first 24 hours on the unit, or something like that, but they're in a modified environment. It also might be people who are in a medical surgical unit where maybe they've modified the environment slightly, but they also have cameras in the room so that they can keep an eye on them and a tech is watching them at all times. And these are line of sight types of patients. The next level is 1-to-1, and we try not to do this within a psychiatric environment because it is a heavily modified environment, so it's very unlikely that our patients are going to self-harm in front of us, but sometimes we do have patients who are very ingenious and intent upon committing suicide, and they are actively trying to self-harm, and you have to place them on 1-to-1, and this requires one staff member to be assigned to that patient to be constantly with them. When a patient is on line of sight or on 1-to-1, it is going to mean that the staff members have to accompany them everywhere, whether to the shower or the bathroom or anywhere, because we have to make certain that they don't self-harm. 15 minutes, on the other hand, is going to be somebody going around and checking on them every 15 minutes to make sure that they're doing okay. So there is a pretty good suicide safety plan template in your book, and obviously for a patient who is actively suicidal, a suicidal safety plan is not going to do a whole lot, but it is something that can help a patient who has stabilized to be able to plan for what would happen if they ever have suicidal thoughts again. For example, in the first step, it says, what are some warning signs that a crisis may be developing, so they can analyze what were signs for themselves that showed that it was becoming a problem. And then it's what coping strategies could they use, and then what people in social settings could provide distraction, who they can ask for help, what professionals or agencies they can contact during a crisis, and ways that they can make the environment safe. So individuals who have had previous suicide attempts may need to have someone else be in control of their medication. They may have to have firearms in the house or knives secured so that they are no longer a danger to the patient. And so this is a really good time when we can work with the patient and the family to create a plan to keep the individual safe should suicidal thoughts return at some point. So do take a look at that. Here again, it's really more about what's going to happen when they leave the unit, not so much what occurs on the unit. But when we send a patient out, we really want to have a suicide safety plan completed. And so this is often going to be one of the goals that we're going to set in our treatment as an outcome. Now, I do want to talk a little bit about the not quite as fatal but still serious part of non-suicidal self-injury. And many times people who engage in non-suicidal self-injury do so to dull the psychological pain with a physical pain. And so there can be many methods that people use in order to engage in non-suicidal self-injury, such as burning, hitting, scratching, biting, skin picking, interfering with wound healing, and even cutting. And we do frequently see cutting on the unit. We'll notice patients who have multiple healed cuts or in various stages of healing up and down their arms and legs. And many times they will try to hide this by doing it on areas of the body that are not as apparently visible. There is cultural variation in what methods people use for non-suicidal self-injury, so this can vary greatly. And it can become fatal, and people who do actually engage in non-suicidal self-injury are more likely to attempt suicide. Interestingly, it does have a statistical probability of 17 to 35% in college students, and is more likely with individuals who have borderline personality disorder or eating disorders. And so, as I want you to know, though, is that this can be something that can lead to suicide, and we should take it, seriously. It did become popular a few years ago among high school and middle school students. So we do see surges from time to time in populations related to what is or is not in vogue at the time.